when there is a failure of IVF cycle, patients start asking about the reason why it is failed, and it mounts the pressure on the clinician. So clinician, most of us start considering it as implantation failure, start over-treating, over-investigating, and overdoing the treatment, which is actually not necessary. I always counsel the patient that IVF is not a magic treatment. It has got its own success rate. They should not expect that she will conceive in a one cycle only. Ideally speaking, recurrent implantation failure should come in mind if there are more than 3 cycles are failed in spite of everything normal apparently, or in other words, 10 or more good grade 1 embryos are transferred consecutively, divided in 3 to 4 embryo transfer, and still there is a failure, it is considered as a recurrent implantation failure. But in practice, we all have seen that typical book picture grade 1 embryos we hardly get. So I would not put it like all to consider recurrent implantation failure, at least 10 grade 1 embryos should have been transferred. No. Reasonably good grade 1 or maybe grade 2 embryos, if transferred and still there is no result, then we should start thinking about the recurrent implantation failure. Now, what are the causes of recurrent implantation failure? To make it simple, there can be a fault in the endometrial receptivity, or there can be a fault in the embryo. In some of the cases, there is multifactorial effect of certain etiologies like endometriosis, or maybe hydrosalpinx, or maybe a suboptimal ovarian stimulation. These are the factors which can affect at different places. So we will discuss one by one. The recurrent implantation failure might be because of undiagnosed uterine pathology. In approximately 20 to 25% of the women with normal initial hysteroscopy or HSG, repeated hysteroscopic visualization after recurrent implantation failure reveals uterine abnormalities, mainly hyperplasia, polyps, endometritis, intrauterine adhesions, and submucous fibroid. So which definitely reduces the endometrial receptivity. That is why in many centers, if one cycle is failed, they immediately before initiating a second cycle, they routinely do a diagnostic hysteroscopy and try to find out if anything is wrong with the endometrial cavity or not. The presence of thin endometrium less than 7 millimeter in fresh transfer and less than 8 millimeter in frozen embryo transfer can influence the results. But the presence of a thin endometrium did not influence the cumulative pregnancy rate in a prospective large cohort studies in 2000, particularly when high quality embryos were transferred. The thin endometrium or hyperechogenic endometrium or persistent endometrial fluid can impair the outcome in tubal factor, but in polycystic ovary syndrome, these findings could not affect the result. The decreased endometrial receptivity may be because of, as we discussed, uterine cavity abnormalities, maybe because of the thin endometrium. It can be because of the altered expression of adhesive molecule. It can be a immunological factor like Apla syndromes, or can be a thrombophilias responsible for decreased endometrial receptivity. The association of antiphospholipid or other autoantibodies with recurrent implantation failure has been shown in some earlier studies, but the large prospective studies fail to reveal an association. So, the screening of thrombophilia in recurrent implantation failure is still a controversial. Now, coming to a embryogenic factor, that is defect in the embryos. Defect in the embryos can be because of the genetic abnormalities carried by male, female gametes or embryos. It can be because of the zona hardening, which prevents the hatching of the embryo and thereby the implantation of the embryo. The defective embryonic development can be because of the suboptimal culture conditions. As we all know, the embryos are very much labile when it is exposed to an adverse environment, and maintenance of the proper pH, humidity, temperature is very much vital. If they face any sort of insult while culturing, it gives a implantation failure. The increased frequency of female chromosomal abnormalities such as translocation, mosaics, inversion, deletion, and chromosomal breakage, particularly at the centromere region, were observed in young women with high order of recurrent implantation failure. The increased incidence of sperm chromosomal abnormalities in patients with normal karyotype and recurrent implantation failure was also observed. Many patients with recurrent implantation failure develop a high percentage of chromosomally abnormal embryos that fail to implant despite good morphology and development rate. The zona hardening, which may be induced by in vitro culture or by in vivo aging, can also affect the hatching. Thus, the failure of zona to rupture has been suggested as a possible cause of recurrent implantation failure. The endometriosis as a cause of recurrent implantation failure has not been investigated directly. However, all markers of reproductive process, including ovarian response, embryo quality, and implantation, and the pregnancy rate are decreased in endometriosis, especially in severe type of endometriosis. So, it is a multifactorial uh, cause for recurrent implantation failure. The hydrosalpinx fluid is commonly slightly alkaline and may contain cytokines, prostaglandins, or other inflammatory compounds. These compounds may have either direct embryotoxicity or adversely affecting the endometrium. The reflux of hydrosalpinx fluid into the uterine cavity may result in diminishing embryonic endometrial apposition. Now, what is the treatment of recurrent implantation failure? It points to the improving the endometrial receptivity, the treatment of embryos, and treatment of multifactorial problems. Now, let us discuss about the hysteroscopy in recurrent implantation failure. The patients who have abnormal hysteroscopic findings and operated on during the procedure, the clinical pregnancy rate is significantly higher in the treatment group. For example, in one study, 30.4% following normal hysteroscopy and 32.5% following hysteroscopic operation, compared to that in control, that is 21.6%. Hence, the treatment of intrauterine pathologies found by hysteroscopic evaluation improved the pregnancy outcome surely. Regarding the fibroid, most of the center they believe the fibroid more than 3 to 4 centimeters should be removed, or if it is disturbing the endometrial lining. But now some of the studies, randomized studies, controlled, they have brought down the cutoff to 2.85 centimeter, irrespective of the location. If fibroid is there, it should be removed. It definitely improves the pregnancy rate. The favorable pregnancy rates obtained after myomectomy lead many clinicians to believe that the removal of the myomas increases the pregnancy and live birth rate. Now, how to treat thin endometrium? To improve uterine blood flow, which may boost endometrial development, low dose aspirin and vaginal sildenafil were suggested in case of recurrent implantation failure with thin endometrium. Many freeze all embryos when the endometrium is less than 7 mm and transfer them after stimulation with high dose of estrogen. Vaginal administration of macronized estradiol to maximize the estrogenic effect, or antifibrotic treatment with the pentoxifylline and high dose of vitamin E has been shown to increase pregnancy rate in case with a thin endometrium. Low dose aspirin is used in 100 mg. Vaginal sildenafil used 25 mg 6 hourly vaginally. Pentoxifylline, we do not have any experience, but vitamin E, if it is to be used, it should be given. It should have been started for more than 2 to 3 months. The estrogen should be given in the luteal phase support in case to prevent to facilitate the proper implantation. The best available evidence suggests that adding estrogen to progesterone for luteal phase support in GnRH analog protocol IVF-XC cycles by different administration routes does not improve clinical pregnancy rate or other relevant outcomes. Further, this meta-analysis demonstrates that addition of oral estrogen during the luteal phase does not improve IVF or XC outcome even with the different daily doses. The endometrial injury or stimulation in the form of endometrial scratch may cause a pseudodecidual reaction that enhances the implantation. In some paper, they have described a protocol for recurrent implantation failure that includes hysteroscopy, curettage, triple antibiotic, and estrogen treatment. The local injury to the endometrium increase the incidence of implantation, although there are some papers which proved that there is another side effect, there will be adverse effect of endometrial scratch. It may create endometrial adhesions and in some of the cases it may hamper implantation process. The benefit of endometrial scratch if it is done in the index cycle is not there. It has to be done in the previous cycle. There are some papers which have shown benefit of endometrial scratch even if it is done before a couple of cycles, maybe 5 to 6 months prior, and it gives a better result if it is done 5 to 6 months prior. But overall, the endometrial scratch is adopted by many centers as a remedy towards recurrent implantation failure. The Stephenson and Flucker, in a double-blind placebo randomized controlled study, included 51 couples with recurrent implantation failure and found that IVIG did not improve the live birth rate. Thus, the effectiveness of IVIG treatment in RIF is still unresolved. The combined treatment of glucocorticosteroid and aspirin has been reported to improve pregnancy rate in autoantibody seropositive patients who have recurrent implantation failure. Is there any role of antibiotic in recurrent implantation failure? Yes, if it is chronic endometritis. The chronic endometritis associated with infection with common bacteria or mycoplasma is a common in women complaining of recurrent implantation failure. And the antibiotic treatment significantly improves the reproductive outcome at subsequent IVF cycle. We commonly use clindamycin for this indication. Sildenafil is really a promising drug. The potential therapeutic benefits of sildenafil includes alleviation of perinatal disorders such as preeclampsia, IUGR, abruption of the placenta, miscarriage, and implantation failure, which all are linked to a poor trophoblast invasion and failure to remodel the uterine spiral artery. Sildenafil directly stimulates the trophoblast extravillous differentiation, which would be favorable for implantation and reduce the risk for adverse pregnancy outcome. The assisted laser hatching can help in case of recurrent implantation failure, especially when the zona pellucida is stiff, which prevents the hatching of the embryo. And if you use the laser hatching, then definitely it improves implantation. This we will discuss in some other talk.